So I'm Betty Keller. I'm the president of the Vermont Physicians for National Health Program. I'm also the co-chair of the Education and Advocacy Work Group for One Payer State, which is a national organization assisting states in trying to figure out how to do this on their own. I'm also a member of the League of Women Voters of Vermont, and we have a statewide committee. I'm on the healthcare committee for the state and also on a national healthcare reform network. I absolutely have a financial interest in Medicare, but so does every other American. So no American can talk on this topic if everyone with a stake is disqualified. So today we're talking about Medicare privatization. We'll be talking a little bit about Medicare Advantage, which has been going on for a couple of decades, and also about REACH, which is new. And that was known as direct contracting when it first started under the Trump administration in 2017. Allowed in the ACA, and with all the hullabaloo of people opposing it, they changed the name to REACH without a lot of other changes. So a little cosmetic. So what is Medicare? Health insurance in the United States is health insurance for people over 65 or disabled. You pay into it while you're working. And then when you become eligible, you pay premiums, and Medicare pays part of your healthcare expenses after you pay your deductibles. Now, it's confusing to a lot of folks. There's these parts A, B, D, no C, whatever. Part A is the hospital insurance. 99% of Americans don't have to pay any premiums on that because if they paid into it while they were working, then for at least a certain amount of time, then they're eligible for getting the hospital insurance without having to pay a premium. If they or a spouse paid into it long enough. Part B is the outpatient care. In that part, you do pay premiums and you do have a deductible, and then you have co-insurance. After you have hit your deductible, Medicare pays 80% and you pay 20%. Now, 20% can still be significant if you have a major health catastrophe. And so we'll talk about that under Medigap. The Part D is for drugs, the prescription medications, through a private company. Medicare has this, they call it Part D, and they have regulations for it, but they don't actually offer that. You have to go through a private company to get Part D. Medigap is what many people who are on traditional Medicare choose to do to have an out-of-pocket cap, because traditional Medicare by law right now doesn't have any cap. And that could be financially devastating. And so that is one of the things we were hoping we could have gotten into the Build Back Better bill last fall, and that did not make it. So it provides for the out-of-pocket cap. It can also, depending on the supplemental insurance plan that you purchase, those are private plans. So if you purchase that, depending on which plan you get, you may have also help with your deductible or also help with your co-insurance. Vision, dental, and hearing are mostly excluded from traditional Medicare. If you have glaucoma or a specific illness, you say you have diabetic retinopathy, then vision is cared for. But for just getting older and having your refraction change, it's not included. So those are insurances that you can purchase separately if you wish. What's Medicare Advantage? This is a program that has changed the way that Medicare pays for seniors' care. In Medicare Advantage, Medicare pays monthly payments to Medicare Advantage plans, and those plans then manage the care for manage, I say in quotation marks, for the seniors and those who are disabled that have enrolled with their plan. So these plans cover Medicare Parts A, B, and maybe also D. They can choose to cover the medications. They can do dental, vision, and hearing, and they are allowed to keep up to 15% to cover their overhead and their profit. So if you compare these two programs, traditional Medicare, the provider, doctor, nurse practitioner, anesthesiologist, whoever it is, sees the patient, charges Medicare, and Medicare sends them a bill, and sends them the payment for the bill. how does Medicare Advantage work and where do they make their money? They insert a middleman between the Medicare program and the provider. So Medicare pays a monthly payment to that middle person, and that middle person pays out to the doctor when the doctor charges. So if they're able to have fewer payments go out than what they take in, they can keep that extra money as profit. That means that you're giving a dangerous incentive to these programs to ration the care, to restrict the seniors' care. These financial incentives do not exist in traditional Medicare. So there are two ways to look at how they can make their money. One is to minimize the revenue that they spend on patient care, and the other is to maximize how much money they take in from Medicare. So what are some of the strategies they use for minimizing those expenditures? So historically, before we did more of this upcoding stuff that we'll talk about later, the way that these companies would do this would be to be looking in places, do their marketing in places where relatively healthy seniors happen to be. So maybe in a gym, for instance. Now they have figured out how to not only take the healthiest patients, and so they are marketing, as you can see, they're marketing everywhere to everyone. But when you're getting all these sicker patients too, what are some of your strategies to try to minimize your expenditures? One is to limit the care that's available for the expensive conditions, so sicker patients will leave. So say a patient's relatively healthy and they choose the Medicare Advantage program, figuring, well, I don't spend that much per year and I'll do okay on this one. And then they develop an expensive condition. And how can the insurance company, how can the Medicare Advantage insurance plan encourage you to leave? They can have networks that are narrow so that for the expensive conditions, you can't find a hospital that will actually provide the care that you need, or the specialists that you need are not in their network. So maybe they have a cardiologist, but not a cardiologist that deals with the more intensive care that you need. And in Vermont, we have more protection, but this is a bigger problem across the country. Another thing is that they don't cover the medications that are needed by the most expensive patients. So it may not even be an expensive medication, but if it's used by a person who requires a lot of expensive care, they may still decide to not cover it. And then the other direction is to maximize the revenue, the money that they take in from Medicare. So by making patients look sicker than they are, Medicare Advantage plans can get higher monthly payments from Medicare, regardless of how much care the patients actually receive. So to explain what upcoding is, let's talk a little bit about coding first. Medicare used to pay Medicare Advantage plans the same amount every year for each person based on their age. In 2006, after a lot of complaints about, the healthiest patients can find plans easily, but how about the people who are cost more to take care of? They were getting dumped off these programs. So they introduced these diagnostic codes for chronic illnesses to acknowledge that some people are more expensive to care for others. So what does that look like? In your typical coding, you would look at this person and their baseline for age. It's a 76-year-old female, so her score is 0.45. And she has some obesity, but that doesn't actually change the score. In type 2 diabetes, that's maybe managed purely by diet and weight control, 0.104. Major depression actually didn't get any extra points for how expensive that person might be to care for. Congestive heart failure, 0.323. Asthma got 0, ulcer got 0. Congestive heart failure with DM, probably diabetes mellitus, is 1.54. And then the total score is 0.103. So the annual payment for this care was $9,000. So now let's look at the upcoding. The age is the same. Instead of just saying this woman is obese, they call her morbidly obese, and they can suddenly multiply it by 0.273 to add to the score. And then they can look at the back of her eyeballs and say, oh, she's got a little retinopathy. So we'll give her a 0.318 instead of a 0.104. Now, interestingly, major depression, a single episode in mild, is like, how much more mild could that be? Like, you've only had one episode and it was mild. And presumably there's not anything going on right now because they said it was mild. And a single episode implies that that episode is done. But they got 0.395. I don't understand that one. Congestive heart failure, they classified it as class 3, which ended up being the same score as what they had before. But the asthma, they called it COPD. If it's chronic lung and chronic obstructive pulmonary disease, they're calling that a 0.328. So on down the line, you can see that this total risk score came up to being 3.63. And this Medicare Advantage plan got $32,000 for the same patient that would have gotten only $9,000 the way they previously coded. You might see that there's a little financial incentive here for them to train people on how to game this system. So Medicare Advantage plans were making money, but only like less than half of people who are in Medicare choose those plans. So they're sitting there thinking, well, how can we get money off of the rest of them? There's a lot of money sitting in that Medicare pot. So direct contracting was introduced in the Affordable Care Act in an obscure section of it where it vaguely says that direct contracting entities, if they either improve care without costing more or save money without worsening care, then a pilot that's tried in one place can be reproduced by basically any kind of an organization. It can be a private equity firm in a different place. And so that was looked at by these Wall Street corporations and private entity firms, private equity firms, as saying, oh, we need to get in on the action here. So these were called DCEs, or direct contracting entities. And after there was a lot of complaint about it, the name was changed to ACO Reach. Now get this, it's Accountable Care Organization. Oh, let me think, what does the REACH stand for? Something like Reinventing Equity and Access for Community Health, or something like that. It's just absurd because it's just like putting together a mumble of words that actually doesn't have anything to do with what they're doing. So what are these programs like? People who signed up for traditional Medicare are aligned with a DCE or REACH program if the primary care doctor they had seen the most in the last few years has a contract with the DCE and REACH. So these DCE REACH programs will go out and try to get doctors onto their programs with contracts. They'll pay them a monthly fee, and then that will motivate, especially primary care doctors where they're having trouble staying in business in remote areas where there's lower reimbursement, if there's a higher poverty rate, for instance. So if they're scraping and trying to make sure they can stay in business to provide care for the community, they are motivated to accept this monthly payment. But that monthly payment ties all of the people that they see into this program that they specifically, chose traditional Medicare, and they're being put into this other program. And so this money that's going to these DCE REACH programs can go to medical care, it can go to overhead, and it can go to profit. So this was the path that we saw with the middleman in the middle for the Medicare Advantage programs. And now behind these companies, you have these private equity firms who are trying to make money on top of that. So this is an example of one of these new direct contracting entities. You'll see the woman there with the red circle around her. She is the only member of this leadership team that is a health professional. She's an RN. No one else in there provides healthcare. Well, so how are these direct contracting entities or REACH programs, are they different from Medicare Advantage? The main thing is that Medicare beneficiaries looked at their options, thought about their health, and decided that they would choose the Medicare Advantage plan, weighing their savings versus their risk. Those who were put in the DCE REACH plans They did not choose them. They specifically chose to pay more per month than to take the savings that they could get on a Medicare Advantage program so that they could have the wider networks, the safety of knowing that if you did develop an expensive health condition, that you would be protected. Another big difference here is the Medicare Advantage plans can keep up to 15% for overhead and profit, but the DC Reach plans can keep up to 40% for overhead and profit. Now there's a scale of like they can keep up to 15, 20, 30, 40 based on a number of criteria, but the maximum they can keep is 40%, which is fairly outrageous that we've been paying taxes throughout our working lives, and that money is able to go for overhead and profit for these inefficient middle programs. Medicare Advantage was approved by Congress, but these DCE Reach plans have not been. The opportunity for them to develop was inserted into the ACA, but there is no set of regulations. There's nothing to really support them being out there, but there's nothing against them either. So they're moving forward. So this is a radical transformation of Medicare. And the CMS is the Centers for Medicare and Medicaid Services, and within that is this Center for Medicare and Medicaid Innovation. And this CMI department within CMS has actually put on their website that they have a plan to expand these ACO Reach programs to all of traditional Medicare within just 8 years. By 2030, they want to basically have no Medicare anymore. So why should we stop this? There's a couple of reasons. A big one is the solvency. You've heard for a few years now, oh, Medicare is not going to have money when you retire and it's going bankrupt and all this. And the reason it's going bankrupt isn't because there's not enough money in Medicare, it's that we're spending it really fiscally irresponsibly. So that with these Medicare Advantage plans, we've already been paying out way too much money. There have been several articles in the news recently about the fraud that's been recognized and about the overpayment. So here we thought we had this Medicare trust fund, we're putting money in the bank, and we're seeing it disappear from these kinds of programs. The other thing is that these threaten the seniors who are on it now, threatens their health and their choices. So when you look at traditional Medicare, the overhead is only 2%. And 98% of the money goes to actual patient care. If you look at Medicare Advantage, up to 15% can go for overhead and profit, but in the ACO Reach entities, they can go up to 40% is diverted away from patient care and into overhead and profit. So 30 million seniors who actively chose traditional Medicare may be automatically aligned with a Reach entity without their full knowledge or consent. How do they end up in there? Their primary care doctor or their doctor's employer. A lot of primary care doctors are now employed by a hospital or employed by a clinic, and they sign it, and their employer signs a contract, and the doctor doesn't even have a choice for those doctors. And the other thing is that managers of retirement plans are sometimes signing one. So that you'll see, like the city of New York had a big hullabaloo about signing their retired employees onto a Medicare Advantage plan. And I think there's also been an issue with them trying to go into a DCE Reach, but I may be mixing that one up. The DCE Reach programs, there's only one in Vermont right now, but there are others across the country that have been started. So how do seniors get out of these ACO Reaches? You do get a letter. Typically, you get a letter that says, oh, you don't have to do anything. But if you want to get out, you can. You have to change your doctor to do that. Like, okay, that's not always easy. So one way is to change your doctor. If you can find a doctor who's accepting new patients and who you feel comfortable with taking care of you. And if they're expecting to have 100% of all traditional Medicare on these plans, then eventually none of the doctors will not be in one of these. The other is to lobby their retirement plan. I don't know how effective they would be, but theoretically that would be an option. And the more effective way to stay out of Reach plans if we all work together to try to end them, rather than trying to get out of it after you've been put in it. So why hasn't Congress tried to stop it? Until January, most of Congress had never heard of direct contracting or this ACO Reach. In January, 54 members of Congress sent a letter to the Health and Human Services demanding an end to the program. So what did they do? Instead of ending the program, they changed the name. So now DCE, realizing, that's what the R is, realizing equity and access for community health. So now these DCE and ACO Reach owners and investors are fighting back to protect their profits. So there was this event on May 23rd, and I will put the link in it for you to find the recording. The program that the campaign they're calling it to try to address this, they called Turning Up the Heat on Direct Contracting. For individuals, you can sign a petition asking to have Medicare stop this privatization. And you can write a letter to your editor of your local news outlet. And this website, which we can put in the chat afterward, protectmedicare.net is the web address for the letters to the editor. And for the petition, it's pnhp.org/DCE petition. For organizations, similarly, there's a letter that you can have your organization sign on to. And you can find that at protectmedicare.net/take-action. And you can share the petition with your members so that the individuals sign that one for individuals, the pnhp.org/DCE petition. And then you can find out more about the fight to protect Medicare at protectmedicare.net. And you can come back to it and see if there's news as time passes, like, how effective have they been, what's happening on it now. Let's see here. So does anyone have a question? So Ellen has one. I want to point out to people that there is a reaction button at the bottom that you can click on to raise your hand that way, and that will put you up in the upper left, so it'll be easier for me to find me, and you don't have to undo your video. But if you don't know how to do that, you can also just raise your hand. Ellen?
There have been some suits against insurers. I think there was one, Sutter Health in California, where they've been found, I don't know if it's a civil suit or criminal, but they've been found, responsible for overcharging this upcoding, right? For directly defrauding the taxpayers by upcoding patients and taking in more money. But what confuses me about that is, that should be criminal, right? Like, if I do fraud, if I'm engaging in fraud on that billions of dollars level, right? And we're upcoding and saying all these patients are sicker than they are, so we can get all this billions of dollars from the government. And they have been found guilty of it and fined, so far as I understand, the Sutter Health case in California. But why is that not, I guess what's bugging me is, how is this not a criminal?
Well, there's a couple of things that bug me. One thing is that if you don't make the fees high enough, the fines high enough, then it's financially advantageous to them to keep on breaking the law.
Yeah.
And we've seen that with polluters anyway. And I don't know, I'm not a lawyer to understand the lines of, which things are criminal cases and all, but it is dismaying that it pays to be a criminal and just pay the fine.
Yeah, and I just wondered if anyone, I don't know, at PNHP or, who would have access to some lawyers to look into this, because it just seems to me that, they pay a fine and walk away and then go ahead and defraud again.
So the other thing that is confusing to me is that in the law, they are supposed to improve care without costing more, or reduce costs without worsening care. And I know you can do a lot of things with data, but if you can show, and we have shown that they are not improving care, or that they are costing more money, then why are they allowed to continue? And why are you able to just move something from one location and reproduce it in another when they might have nothing to do with each other? The populations might have different outcomes. So I don't know what the legal issues are and who's pressing those things. But it seems like, even when you look at the CMMI site, it says it wants to transfer to, accountability. And it's like, okay, show me this accountability. I haven't seen it yet.
Yeah, well, that was just my comment. I let others go because I see a lot of other hands, but it just seems like another avenue would be to figure out if they've been proven to have engaged in fraud, then
I don't
happening.
There should be a lawyer for Medicare for all. I don't know. So I see Virginia has her hand up, and then Linda Andrews. Virginia?
Yeah, you just told us a bunch of really terrifying scenarios. And my question is, how on earth do we know what situation we are in? My husband was a 30-year state employee. We have whatever they're providing. Is that good or bad?
Good question. I think that you have a union, right? So you have union representatives that are helping choose whether you're put into different programs. Is that right?
Well, he's been retired for a while, so we are with whatever we are with.
Mm-hmm. Does the union?
Where do I need to go to find out what the retirees' benefits actually are?
The retirees for the state?
Yeah.
I would think that the union would know that. Does somebody else have a comment to share with that?
I would say the state employees union as well, Virginia. One thing so far in Vermont that makes things somewhat easier to accept is that there is only a single medical practice in the state that is currently a DCE practice, and that is called Evergreen Health, and it's in northwestern Vermont. But no doubt the providers, the DCE investors behind Evergreen Health will seek to enlarge that, and so we will need to be careful and try to read all our mail.
Good idea. So if we're with Central Vermont Medical Center practice, we're probably okay?
I don't know that you can assume that. I mean, you don't know when another practice will sign up for one of these.
Right.
I think it would be great to speak with the management for the practice and tell them in advance that you really are hoping that they don't. I mean, if they see this way to make money per month and just like don't see a downside, then they might just sign up for it. So if you should go to them and talk to how it's bad for the community, bad for Medicare, and bad for the patients. So please don't sign up for this so that their doctors are not aligned with it. So being proactive, I think, would be good, especially since right now we are not where we don't have a lot of them already. So it would be great. And the other thing is to, I put in the chat the links for where that recording is about the May 23rd event. Also, there's a when you go to that page, there's a tab for Take Action, or you can just click on the second link I have there, protectmedicare.net/webinar. Turning up the heat, and if you scroll down to the bottom of the page, it has some things like where you can call and the hours that they're open, like to call the president, for instance, which I haven't done yet. I've been busy with some travels, as I had mentioned, and that reminded me when I was looking at this today, I need to make that phone call myself. I've never called the president before, but this qualifies. And then also it has a one-page handout you could print out to give to the management at your healthcare clinic so they can see why it's a bad thing. And there's also instructions about sharing your personal story. So our chapter has spoken with several of the candidates for national office, but also with candidates of representatives of our current congressional delegation. So when we were speaking with Senator Leahy's staff, they were saying, well, we're hearing about Medicare Advantage, but no, and we're looking at that, but we're not really hearing about these DCEs. So yeah, I guess nobody really is too bothered by them yet. And I'm sitting here thinking, oh my gosh, why would you wait until things are bad and things are entrenched like Medicare Advantages? Why wouldn't you start dealing with it now? So if you can start sharing your stories, practice it so that you're more comfortable with it. Maybe take a video of it to share, or maybe call your representatives, like Welch's office and Leahy's office. Then that might be more impactful than what they're hearing right now. Because right now they're saying that they're not hearing major concerns.
Betty?
I wanted to catch Linda, and I see Martin.
We also have some items in the chat.
Okay, yep. So Linda's had her hand up for a little bit.
Yes. What is AARP supporting?
So that's a challenging thing. The AARP gets a lot of its money from insurance companies. And so I frankly don't try to keep track of what they're supporting, because I kind of assume that they're supporting insurance companies because that's what they depend on for their bread and butter of that's how they pay their bills.
And thank you. I have one other question. Have you talked to our candidates for the the federal U.S. House about this? Because I've asked all of them to try to watch your what you're doing, and I don't see anybody online that's come, and it's discouraging.
So we actually have spoken with them directly. We've had meetings with 4 of them so far. There's quite a few. We've met with either 4 or 5 of them. I don't think we've had a response when we've reached out to the Republican candidates yet. Marvin, you were doing a lot of that contacting. Can you share anything on that effort?
Yeah. Can you hear me, Betty?
Yes.
Okay. We have reached out to 5 of them, and we've met with 4 of them. All 4 of them took the position that we had hoped they would take, that they were opposed to DCE and REACH. And those are Keisha Ram, who now dropped out, Becca Ballant, Molly Gray, and the other woman, I can't remember her name, the younger woman. Anyway, and then Lou Myers hasn't gotten back to us. Anyway, so that's the story. By the way, there was a person earlier who asked about Central Vermont Medical Center, whether they're in a DCE REACH. The answer is that they are not. There is something called OneCare, which is in a part of a similar structure to a DCE, and it has the ability to. Also has incentives to profit when you get less care. However, OneCare is kind of our own baby here, and it's less likely to do the kinds of things that the for-profit companies are doing. And I from the start, I have viewed OneCare as a massive waste of money. It has a track record of not saving anybody money, but now it has this benefit that it's keeping out groups like Clover Health, which is our only DCE in Vermont, up in Chittenden County. So, and I just want, if you don't mind, I also want to make a comment on AARP. And the reason I am is because there was just a headline out today that AARP has not only been in bed with United Healthcare, which is the nastiest of the insurance companies. It's the nastiest. Their profit on $80 billion of revenue, their profit in the last quarter literally shot up to $5 billion, which is an amazing profit rate for an insurance company. $5 billion out of $80 billion revenue. And they are mercenary. If you're in United Healthcare, you are not going to a rehab center without a fight. And it's unbelievable. We just had a patient with a brain infection, literally, this is at Springfield Hospital, where they refused to pay. An old woman was dying, and the husband was 89 years old and very frail. And she was getting end of life care, and United Healthcare refused to pay for that, saying, well, that could happen at home. Well, she had 2 fractures. There's no conceivable way he could have repositioned her and taken care of her. It's nasty. It's just nasty. So AARP has legitimized United Healthcare by getting a massive kickback. And the latest scoop just today, headline out of the Washington Post, is that AARP has now gone into bed with a for-profit private equity firm called Oak Street Partners that is buying up primary care practices across the country. So now, instead of saying you're signing up with a primary care doctor who's owned by a private equity firm, it's going to say an AARP endorsed private equity firm. So, and it turns out they're getting $1 billion for doing it, which is 3 times more than their annual revenue from people who voluntarily join AARP. So AARP is not on the side of, it's put himself in bed with the for-profit sector. It's just appalling. I'm sorry to get off on this, but.
Is there something else you wanted to say, Marvin? You had your hand up, or was it the AARP?
No, I just wanted to say about CVMC. And
Okay.
some of you may know more about OneCare, and we could talk about that. But the center. Okay, so Betty said earlier that the Center for Medicare Services (CMS) is intent on herding every single Medicare beneficiary into one of these deals by 2030. And so one of the deals is either an ACO like OneCare, they count that, or a Medicare Advantage plan, or a DCE. And anyway, so that's sort of their scam, is that everybody's going to get herded into for-profit care, or a not-for-profit one, which is what we have here, this OneCare, and it's probably a little better. It's going to be harder for OneCare to do something outrageous like not pay a hospital for a brain infection. It's very sad.
Right. It's really dismaying that our state has been nurturing this OneCare organization, which basically is a pilot. Like when they say these DCEs have to be based on something, this OneCare is one of these pilots on which something could be based. On the other hand, in the short term, it is protecting us from other ones horning in because CMS wants us to be a good pilot. So I'll let does somebody else have a question? I'm going to actually, while I find these to put in the chat, I'm going to let Ted read the questions out of the chat and Marvin answer them while I grab these petition links.
Walter has his hand up. If you want to.
Oh, hey, Ted.
First.
My question is, and Marvin took a lot of what I had, but one question I have is, how do we stop these programs? And just writing your congressperson isn't enough. And the second part of that is that on Clover Health, what we can do is barrage, not write, but barrage the Green Mountain Care Board on Clover Health, let them know. And that would be a good place to start. But we not only have to, we blunt these, we have to stop them. How do we do that? And writing Congress people isn't good enough. And calling Biden is, because Biden's doing it because he's getting paid, he's getting well paid by the equity firm to do it. That's why they're doing it.
Yeah, I'm not sure about the lines you can draw directly there. He's not, I mean, he could run for a re-election, so there is the issue of campaign financing. So that's the other thing. Our whole system is messed up by the way campaign financing works on so many issues. So I did put into the link the petition for individuals and the petition for organizations. I see that Ellen put in a link for Kaiser Health News, an article on the AARP marketing.
Okay. Item on the chat from Alice Leeds. Can you talk about the best Medicare options for seniors right now in Vermont and how to switch programs? By the way, this year, Vermont retired teachers will switch to Medicare Advantage.
So a big problem actually is that if you go on traditional Medicare when you turn 65 and you sign up for one of these supplemental plans and one of these Medigap plans, then they have to give you a reasonable rate based on the health that you have at that time. You can't, and once you're on it, I'm not sure what you use the word, but the insurance company will be considering you a certain risk and you'll be carrying that with you. If you go on the Medicare Advantage at a certain, at a certain healthy level, and then you get sicker, and then you want to get back onto the other so you can have the wider networks, you lose that, and they can increase what your premiums would be over what they would have been previously. So the rest of your life, you're actually basically paying a penalty on that. So it's very hard and financially disadvantageous to be on a Medicare Advantage plan first and then try to switch out of it. Some states have actually passed laws that the supplemental plans can't charge you that extra when you switch over. I think there's only like about 4 states to do that. There's pluses and minuses to expending your energy working to try to improve that safeguard for Vermont compared to trying to work at the more national issue of trying to get rid of the Medicare Advantage plans and the DC Reach programs in general.
Mm-hmm.
Marvin, did you want to, Ted, go ahead.
Well, I was going to do another chat unless Marvin wants to comment.
Marvin.
Yeah, well, let me just say, Walter asked what you can do. I think the simplest thing for us to say right now, Betty has described several things. I think you should get on the internet, go to the PNHP website, Physicians for a National Program, and there are several things that they talk about that you can try to do. And if it's not clear, call them on the phone. Ask them what they can do, what they recommend you do, and they're part of a coalition. I think you can get in touch with Betty, who's a president of Vermont's PNHP chapter. You can, or if you're part of a church, you can organize your for us to give a talk at your church. So there's a lot of things to do, but please just let us know, email us, or let us know in any way you can.
So a lot of it just is building the number of people who even know this is a problem and understand how big of a problem it is, so that there are more people going to their Congress people about it. Now, Walter said that if you just contacting your congressional delegation is not enough, and he's right that especially in our state, that's not enough. What we really need to do is to be reaching out to our friends and relatives in other states. So our congressional delegation is all voting in ways that would protect Medicare. They're all signing those petitions. So sending more letters to them is nice to say thank you for doing these things, but it's not going to change the outcome. So what we really need to do, and Bernie is occasionally having hearings on things related to this, but what you really need to do is to be contacting friends and relatives in other states, and especially people in states where the congressional delegation may be open, might be receptive if enough people complained at them, but right now they haven't bothered to act on the concerns that they've heard from so far. So just building up that that anger across the country about what they are doing to our Medicare program. Mm-hmm. The other thing is to just be struggling to get Medicare for all. All of this would be moot if we had a Medicare for all system that was publicly funded and was adequately protected, that Congress couldn't be writing things to start privatization or something.
Mm-hmm. Comment from Mark. Retired state employees should contact the retirement office for specifics. And then he points out that Medicare and all Medicare folks are currently in the ACO operation, which is OneCare.
So when Alice asked what is the best Medicare option for seniors right now, I mean, staying on traditional Medicare and then figuring out what supplemental plan makes sense for you. Make sure that whatever plan you pick covers the medications that you're on or the doctors that you need to see. The supplemental plans can be switched between those over time. It's the switching between the Medicare Advantage and the supplemental plans that's the problem.
Right. Second, a comment from Barbara. If United Healthcare is so bad, is there a supplemental insurance program that is good or at least better? Marvin, Betty?
I frankly haven't explored the supplemental plans. My husband is still employed, so when he got that stuff, he did what he needed to sign up for without doing a lot of research to choose a plan. But there was like plans A through H that were sent to us for the supplemental plans. And I haven't researched that yet. Marvin?
Yeah, can you hear me?
Yep.
Yes.
Okay. That was a good question. United Healthcare, in a sense, is doing at least three things that are easy to talk about. One is it's providing HMO or managed care type insurance to younger people under 65. The second thing is it has a heavily promoted Medicare Advantage plan for people over 65, and it probably sells supplemental insurance if you've chosen traditional Medicare. If you choose traditional Medicare and you're not getting a penalty because you were in a Medicare Advantage plan before. So anyway, if you're I turned 65, I signed up for traditional Medicare, and I pay $155 a month for a supplemental plan. That's $2,200 a year, including the drug plan I had to sign up for. And for a lot of people, that's a lot of money. So and on television, they're trying to lure you into Medicare Advantage plans. But basically, when you're buying supplemental insurance, when you're in traditional Medicare and buying supplemental insurance plans, it's usually the amount of money that the supplemental insurance company is losing if you get a lot of care is a whole lot less than what they're losing if you signed up for their Medicare Advantage plan. So their main efforts at denying care are not in their supplemental insurance plan. I mean, personally, I wouldn't sign up for it. I wouldn't have anything to do with United Healthcare. I mean, it's bad enough that I have to treat patients who have it. But, to be victimized, to actually be somebody who's enrolled in it, oh my God. But anyway, their supplemental insurance plan, they're probably not so mercenary. They're probably going to behave a little better because the motivation just isn't there as much. And there may be regulations about that, but all of this mercenary activity that United Healthcare and Humana and these other companies do, for people in Medicare, you're talking about the Medicare Advantage program. And then if we let DCEs happen, eventually, if we're all herded into a DCE, then we won't be so protected. But for now, we're relatively protected because probably OneCare will just take too much heat if they start behaving like this.
So I'd actually like to make one clarification. I don't think I made it clear in the talk, was that so the DCEs were created in the Affordable Care Act, and they started developing them in 2017. They've been more online over the past year. And in January or February, they made that decision to change the name of the program. So that what they basically said is that the DCEs that are currently under contract all end on December 31st of 2022. And any of those that want to become a REACH program have to re-sign up and go through the process again. And so they are saying that the REACH program starts on January 1st of 2023. So what we basically, so when you're, just so it's easier for you to know what you're asking for in your letters or when you're talking to your Congress folks and all, is we want them to stop the DCEs and we want them to not start the REACH program. We want them to cancel the REACH program, just stop it now. So that's what
Yep.
we're asking for.
We have about 6 minutes left in the program, and I have a really good comment or question in the chat. Lee says that she's interested in knowing how federal community health centers are anticipating DCE and how vulnerable they are. Will they be affected also? This is particularly relevant for Springfield because the primary care clinic at Springfield Hospital, now called North Star Health, is a federally qualified community health center. Does anybody have information on that? On that question?
Marvin had
I
his
do,
hand
Ted.
up before, but okay, great.
Yeah, I know that answer. In the most recent issue of Health Affairs, there's an article describing a new initiative on the part of the Center for Medicare Services, the same regrettably poorly functioning federal agency that's doing this to us. And yeah, there's an initiative now. They haven't involved community health centers, otherwise, or FQHCs, which are sort of the same thing, but they're gonna do it. And they're, you know, a lot of this change, this rebranding, this new name they gave themselves, you know, starting January 1st, as Betty said, it's mouthing, it's under the guise of trying to take care of minorities, like dealing with disparities in care or the worst care, you know, the worst care and outcomes that minority communities have. But it's, I mean, Frank, I'll just give you my opinion. I think the whole thing is a smokescreen. They're just intent on creating managed care structures, hurting everybody in Medicare. They're admitting that. I mean, they're saying that. Admitting isn't even the word. They're overtly saying that everybody's going to be in one of these structures. And so everybody includes FQHCs, and that's their new initiative. They're working on how to get FQHCs in community health centers. And I just want to comment on that. I've worked in community health centers for much of my professional life. It is a very difficult job. And when you work there, you're in primary care. No specialty is more poorly reimbursed than people who work in primary care. And now that they're going to impose all this extra bureaucratic stuff, because there's going to be a whole lot of bureaucratic expectations when you're in these new things, you know, these REACH, DCE, whatever you want to call them. It's just, are they trying to drive people out of primary care? That's my question. Like, it's just, I mean, the whole thing is so appalling. This department, I mean, I have my own opinion about it. I think that the head of that agency, Becerra, the head of Health and Human Services, just doesn't know a whole lot about this. And the woman who's the head of the Center for Medicare Innovation, Liz Fowler, I think she's the brains behind this whole thing. And she's, you know, she's out of the insurance industry. That's where she's worked. And she's also worked for the pharmaceutical companies. Has she ever changed a bedpan or treated a patient? No, she has not. And this is the kind of person we now have in that office. And it's really unfortunate. So yeah, I agree with Walt. I think we need to fight this. You know, get in touch with Betty, get in touch with the PNHP nationally, and, you know, think of every way that you can to fight that you can think of to fight this, and let's work on it.
So I would like actually Marvin to comment a little bit about two things, you know, trying to keep the presentation short so that you don't all get bored, and then expecting the questions will come out, but a couple of them didn't. So Marvin, can you speak a little bit about the vision, dental, and hearing, the pot of money that is saved for Medicare Advantage that traditional Medicare is not allowed to use? Can you talk about that a little bit?
Yeah, I was actually part of the writing committee for PNHP that was writing on a comment on the decision made in the last few months to overpay the Medicare Advantage plans even more, so that Joe Namath, who's on your TV promoting these plans, you're going to see even more of Joe Namath because they're being so grossly overpaid. So their overpayment is, there are multiple parts to their overpayment. And one of them is there's a separate fund of money. And if they jump through a set of hoops that are pretty much bureaucratic, they get extra money to provide special benefits. The other, or they can reduce your premiums. And the Medicare Advantage companies have received these overpayments from the federal government and taken advantage of them by reducing your premiums and offering 3 sets of benefits, other benefits. One is a partial dental benefit for a little bit of dental care. Another one is to give you, I think, a pair of eyeglasses a year, so a vision benefit. And then the third one is some hearing aids that you can get a hearing aid every few years or something like that. And they got this extra specific overpayment to be able to offer this to people who sign up in these organizations. And I just think it's absolutely appalling that people who sign up for traditional Medicare, who are paying $2,200 a year, do not have access to that benefit. And I strongly encourage you to complain about that. Say, this needs to be in traditional Medicare, period. You're overpaying Medicare Advantage plans who are siphoning off money, depleting the Medicare trust fund. This needs to be in traditional Medicare now.
Thank you, Marvin. I see Ellen has her hand up again. So we're closing in on the hour. I don't know if SAPA needs to stop recording, but I had in mind when I was planning this that we might go as late as 8:15 because there often are a lot of questions and it's a complicated topic. So I don't mind staying on, but I also realize that other people may have other plans. But including Ted, if you have other plans, I appreciate that.
No.
Okay. So Ellen, you had a question?
Yeah, 2 points. Somebody in the chat made a super strong, good point that I just wanted to raise. And that is that, even here in Vermont, a lot of people do not have a choice anymore. Like the teachers were basically, shafted or channeled into Medicare Advantage, right? Because the state, what's her name, Beth Pierce, thought that it, would save money, just like the retirees in New York City. So we say Medicare Advantage, we say, people at least have a choice, they can choose not to do it. But increasingly, retirees are being channeled into that as a group. So that's something that should concern us here in Vermont, where, we've just seen all the teachers, and I've spoken to many retiree teachers who, got stuck with that. So that's the first point that I want to make. And the second point I wanted to make and I forgot, so I'll get back to you. But I think that's something we need to really seriously think about because it's not even a choice. Oh, this was the other point I wanted to make about Medicare Advantage, that the hearing and the vision, this is why Bernie was pushing so hard in Build Back Better to get hearing and vision to be part of regular Medicare, because one of his reasons was obviously he thinks people should have hearing and vision care, but secondarily, it would be a further way to have people not be induced to enroll in Medicare Advantage. But of course, that's if it's a choice. Many retirees do not have that choice.
Right. So there's the two major things that are incentives for people to go onto Medicare Advantage plans. One is that cap. It's really scary to not have a cap. So then you feel required to purchase a supplemental. And then as Marvin was pointing out, the supplementals are more expensive than the Medicare Advantage. And the other is the dental, vision, and hearing. So those are our major inducements to people to want to choose the Medicare Advantage plans.
Those who can choose. But then again, we've got that further problem of whole groups of retirees now cannot choose.
Right. Now the other thing is that just to make sure that people understand that Medicare Advantage plans can just plan to undercut the supplemental plans because they can do this coding to make more money per patient. So if you know that you can do all that upcoding and get $32,000 instead of $9,000, that's why you can offer gym clubs and prescription plans too. As long as you keep the expensive prescriptions off and keep off the medications needed by expensive patients. But you can offer those extra things and not even charge a premium sometimes. Some of these plans don't even charge any premium and they offer so if you're on a fixed income, it's very understandable that you might feel financially forced to have to choose the Medicare Advantage plan because your budget just doesn't allow food and heat and a roof over your head and, a premium.
Which gets into why we need Medicare for all, because we'll
Right.
never save Medicare if we don't have everyone in one pool in the end.
Right. So you have all the administrative savings, plus you would have a progressive form of
Exactly.
public funding. So I have Stephanie Woods has her hand up and Alice Leeds. Stephanie? You're muted still. I saw you had a question in the
Yes, about the naturopathic services, but that could apply to anything. In other words, you talk about dental, vision, and hearing being options. But from what I understand, in other states, Medicare Advantage plans also offer other options like gyms and naturopathic services. And so why does the Vermont Blue Advantage say that they don't have the option of covering naturopathic services? Is that true, or?
So Marvin, she sent an email today and I didn't have time to research it. Maybe you know. So does Medicare, traditional Medicare, cover naturopathic services now?
I don't know that. I don't know that answer. I don't know if someone else does.
No.
Okay, so they don't cover it.
Doesn't, right.
Yes, they do.
There
They do
are
cover it. I've had
Medicare
it covered.
Advantage plans that have it covered.
Oh, I'm sorry. Can somebody who just said that they do cover it?
I'm Alice Leeds. I'm the teacher who was switched from traditional Medigap. And when I was on Medigap, I had some of my naturopathic care was paid for, and that was as soon as I got onto Advantage, that was cut off.
So maybe that was covered by the Medigap plan rather than by the Medicare traditional plan.
Yes, the same thing.
Probably was, but it was
Okay.
something I know I lost when I got onto Medicare Advantage.
Okay.
But I mean, are they lying to us that they can't because now we're federal, we can't do state things? Why? Or are these other states doing some magic, these other plans in other states like Oregon and Washington doing magic so that they can get naturopathic services into Medicare Advantage plans?
Yeah, I don't know whether they might have a waiver or something if there actually is a rule on that, but we could check into seeing if we can find the answer to that, because I don't know that answer. So Alice, you had another question beyond that?
No, I just wanted to give some information that when, now I'm forgetting what I was going to say. I put this in the into the chat, and let me see what I put, because I wanted to just make sure people heard. Oh, so when I got onto Medicare Advantage, I looked into getting my dental coverage, and at least one of the dentists I go to, they just about laughed when I asked, not the dentist, but the person who was looking into it. Because the thing that they make it sound like out of network is some select group that they pick. What it really is those are the doctors who are willing, and the providers who are willing to work with them and are willing to, and they pay a mere, like a ridiculous fraction of what they're billed. I mean, it's unbelievable. It's amazing anybody's willing to work with them. And so they're only, so the eyeglasses, I think they have their own eyeglass person that you go to, and probably their own eyeglass frames. I don't know. I mean, it's very limited what they provide. My dental care has not been, I've gotten nothing dental wise, and I don't use any hearing aids at this point, but it's pretty bogus in my experience, what they offer, at least the Blue Advantage or Advantage Blue, whatever it's called.
Right. So I know that for private insurance, for those who are not on Medicare, that there are rules that that an insurance company has to provide, has to include patient providers who are within at least I forget if it's 50 or 30, I think it's within 50 miles of where you live. So that if you say that you provide, if you say that you're providing insurance, then you can't have somebody not covered. Let's say you needed a urologist and the nearest urologist in your network was 100 miles away. They have to pay to let you see a urologist who's closer. Okay. So it would seem to me that Medicare Advantage would have to follow the same rules, except that because it's federal, maybe it's exempted, and maybe we can't do that regulation that helps helps insurance companies not take advantage of us.
Yeah.
So Marvin
Yeah.
has his hands up and Linda Andrews. Did
Yeah,
Marvin
I
have
just
any
wanted to
comments
make a-
for Linda also, for Alice also?
I want to make a quick comment about the naturopathic question. If you look at the way that Medicare Advantage plans operate, I would suspect that they may well be willing to cover naturopathic care, because naturopaths are not performing heart surgery. They're performing primary care mostly. Lower tech care that is not expensive. These companies are not going after primary care largely. They're going after, if you get cancer, that's what they're going after. If you're prescribed a drug that's $100,000 a year, good luck if you're on a Medicare Advantage plan. People try to disenroll once they get a big illness like that. So naturopathic care is not something that they would feel bad about. It's something I wouldn't be surprised if they covered it. The problem is, if you get sick, you could get sick. I mean, you don't know what's going to happen. And if you do get sick and you're a Medicare Advantage plan, watch out, because it's out of control. And so all I can tell you, it's very bad.
Right, but it sounds like some folks here in Vermont have specifically sought naturopathic care and been denied. So that's unfortunate that they're not all agreeing on that.
We've had it for like 10 years, and UVM swore that we weren't going to lose coverage, but they missed that one and they weren't willing to step up, even though I agree that it's going to be a lower cost kind of service provider, and there is data to show that. So
Yeah.
I don't know how individuals, retirees and others have any leverage to do anything about it. And a lot of people that are being affected are not in a position physically or in other ways able to really fight it. So it feels like it's really a predatory practice.
Yeah.
And it feels like, the profit margins are going around, and there's all these systems, and there's nothing to stand on to say, hey, I'm drowning, or what, help me.
Yeah.
And
I'm so sorry to hear that.
I wanted, if I could, there was one other thing I had wanted to point out for people who might be on Advantage, is that they've started sending me all kinds of forms to fill out about my health. And I'm not going to send it to them. They say, free health evaluation. And my guess is it's just to find out if there's anything more they can collect on me.
Exactly.
So
Exactly.
I would not
they
give
code
them
you
any
up.
information. Yeah.
Thank you. Good strategy. Okay, Linda.
Yes, I just wanted to understand what you were saying. I was thinking it might be important to lobby the legislature to make it illegal for people who do want to change from the Medicare Advantage back to the traditional. I mean, I know the teachers can't, but if they want to go back to the traditional, should we put effort into trying to get a law that says, it's illegal to increase the supplement that they had before?
We haven't taken a position on that specifically. We've talked back and forth on the pros and cons. So there's a state level of PNHP, and then there's a national. And I'm not aware that either. I know the state hasn't taken a position on that yet. And I think that the national was sort of discouraging taking that and just asking us to put all of our efforts into trying to get Medicare for all. Marvin, do you know anything different?
Yeah, I mean, the reason not to support that is that if that kind of thing passes, okay, so let me just say, so the average person who starts out in a Medicare Advantage plan and then gets gets into traditional Medicare and is trying to buy a Medicare supplement plan, the monthly fee, I think, often goes up from around 155 to 260 or so. So it's a meaningful increase. It's a reason, a fair amount of money, $1,200 a year, that would be. So obviously people don't like that, and so they could argue against it, and that's the predicate behind the push for these state laws. But keep in mind that if you pass a law like that, then it would make sense. It would always make sense to sign up for a Medicare Advantage plan while you're healthy. And then as soon as you get sick, you know, the Medicare Advantage, while you were healthy, the Medicare Advantage company made all this money off of you while you're healthy. And as soon as
Draining
you
the
get
funds.
sick, without a penalty, you can do exactly what they want you to do, which is to get out of their plan
They wanted
and
you to
go
leave
back to the
them.
taxpayers, to traditional Medicare. So in a sense, you could say that that type of bill is sort of subsidizing the Medicare Advantage industry by getting rid of the only disincentive, well, an important disincentive. I'm not saying I'm opposed to you. I get it. I understand the
I know.
logic.
I mean, you want to help individual people who are struggling financially, but you don't want to help the insurance companies that are strangling us either. Ellen?
Yeah, I kind of think can you hear me?
Yep.
Yeah. So I kind of think the thing about this is, I respectfully, I guess I would say I don't think it's a panacea, but it would be fine if a bill passed that allowed people in Vermont who got stuck in Medicare Advantage to get out of it without penalty, because I do think, I mean, this isn't going to solve all our problems, obviously, but I feel like there are people stuck in Medicare Advantage in this state who did not even choose that.
Who didn't choose it? They didn't
Yes.
make that
And
decision.
what I put up on the in the chat, and I'm not saying it's something that you PNHP in particular would spend a lot of time on, or any, but there was a bill that Mike Fisher, the healthcare advocate, had put forth in the Senate Health and Welfare in Vermont this spring, and it would have made it possible for someone who had to get out of Medicare Advantage during the open enrollment period, which is also sort of limited, but to get back into regular Medicare and not pay a penalty with their supplemental. That's like, there are 4 other states that have this, not a whole lot of states. I think
Right.
New York.
So
It didn't, just to go real quick, it got nowhere because Blue Cross Blue Shield markets the supplemental. They went into Senate Health and Welfare in Vermont and they complained, bloody murder. And so the bill was dropped. But it just shows you, even in Vermont, when an insurer goes into a Senate committee and makes a stink, then like the thing gets dropped like a hot potato. And I know I understand what you're saying, Marvin. There are things on both sides of this, but it's just an example of, just trying to provide some relief. It's not going to solve any systemic issues. But
you could see that the insurance company selling the Medicare Advantage plans might go in there and say, hey, yeah, please support this.
No, the Blue Cross Blue Shield didn't want it because they don't.
Because they sell a supplemental and they want to
sell
charge
the
higher.
supplemental. So it's just an example of the power of insurance companies, even on, if the way I would look at this is it's relief for people who get stuck.
Yeah.
Anyway, be that as it.
Yeah, I just want to say, Betty made it sound like there's not enough work to do within Vermont, but I personally would like to hear Peter Welch and Leahy be a lot more vocal to add a dental, vision and eyeglasses, these benefits to Medicare. And Betty pointed out that there's no ceiling on how much money you have to pay if you're in traditional Medicare.
The cap is the most important.
Let's do something about it.
Those
And I'd like to hear Peter Welch and Leahy do something about that. I think we have work to do in Vermont. I want to hear them say something. I want to hear them speak in public about it.
So one thing is that my son had said that when he was in Senator Leahy's office as an intern during college, is that when you're writing a letter to the editor, to be sure that you include the name of the people that you would like to actually act. So like put Senator Leahy's name right in the letter to the editor. We're hoping that Senator Leahy will blah, blah, because every morning, those interns, they go in there and they do a Google search and see where their senator's name showed up. And then they tell them, oh, people are saying this about you in the news. So I think that letters to the editor that call out the senators might be more effective than letters to the actual senator, because I know I have sent emails to my congressional delegation and I sometimes will get this ring around, oh yeah, we supported this. No, that's not the bill I asked you to support. This one. Yeah, it could be more effective to actually write the letter to the editor and then encourage other people to also write letters to him and to the editor. So Marvin is right, especially for this DCE thing. Leahy is going to retire, but he is in there now, and we want action right now. This is the time to be telling him, you know, even if we are not seeing Medicare for All happening in the next couple months, and, you know, Senator Leahy did actually sign on to Senator Sanders' bill again, but DCEs are right now. That's, you know, that's really important. So sending those letters on that specifically right now is important. But it's really, it's an executive action thing that we don't need to pass a bill. We just have to convince, you know, Becerra and Biden. One has to, you know, Becerra's not going to do it unless Biden says to. So you have to like get them behind this. And I don't know how we create that rise to get that. And I think it's more senators from a broader range and Congress people from a broader range of places. Oh yeah, those Vermonters, they're saying to stop the DCE program. Oh wait, is Michigan asking us to stop it too? Really? Huh, Iowa, really? Then that would catch more attention. So thank you so much. I don't see more hands right now. You do have my email address, the WAITTVT. We're all in this together, Vermont, @gmail.com. And thank you so much for joining us this evening, and go ahead and send more questions if you come up with them. And Alice, I think I have your email address already because you already wrote to me, or was it somebody had a question that we said we would check in on. So just make sure that you stay on after the recording is done and make sure I have your question. Stephanie, I know I have your question because you sent me an email.
Wasn't me, Betty. It must be somebody else. Yeah.
Okay. Okay.
Thank you.
Okay. So I have Stephanie's question. Okay. Thank you. Okay, folks. Thank you so much.
Thank you.